So as with any Cavus talk, I'd be remiss if we didn't give credit to the guy that wrote all the papers to help us decide what to do, Dr. Manoli. And so there you go, Art. So we're talking about subtle Cavus rather than the post-polio. So this is the non-neuromuscular variant. It's a normal variant in the population, 20 to 25% incidence. And this tends to be more forefoot driven and more subtle. And so if you think about gait cycle, normally from heel strike to mid stance, the hindfoot's everted, the show part joints are unlocked, and the midfoot is therefore flexible as a shock absorber mechanism. And so as the foot goes from terminal stance to push off, the hindfoot inverts by way of the posterior tibial tendon, which locks the show part joints and turns the midfoot into a fixed rigid lever for forward propulsion. So certainly this is all out of Bruce St. George's 3D reconstruction, weight-bearing CT scans, and you notice the difference in people's alignment in terms of the valgus hindfoot versus the neutral versus the cavus. And you can imagine with body weight stresses, when the talus sits right on top of the calcaneus, there's nowhere for it to go. So with subtle cavus, you have no hindfoot eversion and the show part joints remain locked throughout the entire gait cycle. So you have no shock absorbent. And so the coronal plane stresses get absorbed by the ankle joint. Most of the subtle cavus is going to be forefoot driven. So plantar flex first ray, and it has kind of a kickstand effect on the tripod that we'll show in a second.